All right, everyone.
Check,
so
1, 2.
We are going to get started with tonight's program. Thank you so much for joining us for this event, Unleashing the Power of Outreach Testing. This session is being sponsored by OraSure Technologies, which is the creator of the OraQuick testing platform. My name is Gretchen Weiss, and I'm the director of the HIV, STI, and viral hepatitis program at NACCHO, and want to thank OraSure Technologies for inviting me to moderate this session tonight, and also for being here for a second time this year, sponsoring and exhibiting at NACCHO Annual. We really appreciate it. So I'm just going to start off with a few words to set the stage for what we're going to be talking about this evening, and then we'll turn it over to our panel here. Each has a brief presentation, about 15-20 minutes each. Really looking forward to hearing from them, and then we'll open it up for question and answer. So in terms of setting the stage for this discussion, while we have made great progress in our battle against HIV, and just in the past few years have seen significant advances in our ability to prevent and treat HIV and hepatitis C, and very notably with hepatitis C curative treatment, the battles continue, with HIV and hepatitis C rates continuing to rise among certain populations. Testing is a critical component of our efforts to end the HIV epidemic and eliminate hepatitis C. Only when people know their status can they get the care they need, whether that be for treatment if positive or prevention services if negative. Testing traditionally and most regularly takes place in healthcare settings, such as public health clinics and by primary care providers. However, we know that we need to expand our testing efforts. It is estimated that 1 in 7 people with HIV don't know their status, and that only about 50% of people living with hepatitis C have ever been screened for it. Outreach testing in non-clinical settings is an important strategy to expand access to testing. However, building and implementing outreach testing programs is no small task and may seem out of reach for many health department programs. We're hoping that through the conversations tonight, through the presentations and the discussion that follows, you will be better equipped to think about how you can initiate or expand on outreach testing in your jurisdiction. This evening, you'll hear from 3 experts in the field about their experiences with outreach testing. Each speaker will address a specific stage of the process for getting an outreach testing program up and running, from making the case for outreach within your team to decision-making and planning, and lastly, implementation and continuation. And then, as I said, after we hear from the speakers, we'll have a question and answer session. And so with that, I will introduce our first expert speaker, Susana Williams Keeshin from the University of Utah, who will take us on a deep dive into the conversations and decisions that need to be had internally when deciding to launch a new outreach testing program.
All right, thanks. Hopefully I can figure this out. Okay, so I'm also going to talk about a program that we recently initiated along with a free PrEP clinic that recently opened its doors. So before that, you have to understand a little bit of background in Utah, and specifically Salt Lake City, where I'm from. So nationally, we know that about 54% of people have ever been tested for HIV, and this is adults. However, if we look at my state, Utah, it's 26%. And if you look at the county I live in, which is the highest county where we have testing, it's only up to 28.4%. So we are the last of all 50 states for screening of adults, and I would also add of adolescents. I'm a pediatrician and I'm an internal medicine physician, so I see both the entire spectrum of HIV. So why are people not being tested in Utah? I think that's basically, you can think of it in 3 different ways. So there's the community level. Specifically in Utah, we don't have expanded Medicaid. We have a large population that doesn't have any access to medical care. We're also very geographically isolated. Even though Salt Lake City is a fairly small city, geographically it's quite large, and to get from one end to the other takes about an hour. So there's the personal level, and this is the same, I think, nationally. There's so many people that are unaware of their personal risk factors, and then there's the other component that they've never been offered a test. So specifically in my realm, which is the provider realm, last year I did a study of looking at adolescent and youth providers, so specifically those that take care of people from 15 to 24 years of age. We asked them things like, what do you do about STI screening, HIV screening, as well as HIV pre-exposure prophylaxis or PrEP. So we found about 20% felt comfortable discussing HIV risk factors. And then when we ask, why are you guys not screening? Why are you not testing? The two number one answers, that 79%, said, well, my patients aren't having sex. And the other answer was, there's a low prevalence of HIV in my patient population. So my answer to that is a specific, I come back with statistics. Well, did you know 2/3 of our chlamydia cases in Utah are between the ages of 15 to 24? So clearly people are having sex. And then I asked, are you aware of the CDC guidelines for screening for HIV? 75% said, yes, I am. Well, what are you doing about it? Who's doing it? Only 16% of these providers reported always or often screening for HIV. So clearly we can see the problem in my state. Continue with a little bit background. This is HIV in Utah by race and ethnicity in 2017. It's not much different than the rest of the US. 31% are minority, primarily Hispanic and Black. When we look at new diagnosis by age group from 2013 to 2017, again, pretty much the same nationally, we find about 55% are under the age of 34, and the one age group that we have not had control of in the last 10 years is the 15 to 24-year-old age group. And I didn't mention also, when we look at by transmission rate, it's very similar to the national standard. About 68% are MSM or MSM and IDU. So planning, thinking about an outreach project, what were the things I'm thinking of? And I do think of getting the low-hanging fruit. So who do we target? Well, we target, for us, it was those most at risk. And then the other thing is, who have we worked with? Who do we feel comfortable with? That was the other big question. So I'm also a PrEP provider as well as HIV, and I see this huge distinct difference between these two populations. One, my PrEP patients self-identify as themselves at high risk for HIV. Many of them, if not by the end of our visit, have already been tested for HIV. All of them will have received HIV risk reduction education. So it's an interesting little group. With this project, we were also, a colleague and I, were starting a free PrEP clinic for those that don't have insurance in Utah. So thinking about these things, we came up with our project concept to identify those highest at risk for HIV in Utah, so young, Latinx, Blacks, MSM, by utilizing social networks. So we plan to recruit patients from our free PrEP clinic, and we offer them an incentive. We say, hey, if you can get 5 of your friends to do an HIV test, great. We'll incentivize this, and we'll either give you a card so they can go to Walgreens and get a free test, or if they want to come with you in clinic, if they happen to be there, we'll test them right then and there. So some issues came up with capacity and also some of our roadblocks. So one, I'm assuming these social networks this is the same population that I'm trying to get to. So I'm assuming my PrEP patients are young, minority, MSM, people who inject drugs, perhaps they have a partner who's HIV positive, and I'm also assuming that they're or underinsured. Communication. So this is the biggest step and the biggest problem, but pretty easy to solve. So as a physician, I always teach other physicians, you have to communicate to patients how they communicate amongst themselves. So if I'm with a 14-year-old, I'm not going to give them a call and give them their test results. I'll probably text them. So you have to know how to communicate with whatever age group. So with this, how are we going to get to this population? Through their friends, because I don't have any other way to get to them. And then some capacity. We have some issues because we are a fully free clinic. It's fully volunteer, so we volunteer MAs, we have 2 physicians, we have 2 to 6 medical students or dental students, NP and pharmacy students, and we also have 1 to 2 case managers each clinic. I identified a medical student lead for this Project, who was very enthusiastic and actually helped us get this clinic off the ground. And then the other thought is, do we even have time to do this in clinic, recruiting these seed patients? Because the total visit's 45 minutes, and it's actually a pretty easy sell. So how do we follow up? So with these PrEP patients, one, they have to come see us every 3 months. I'm also calling them usually 2 or 3 days after their visit, and a case manager also follows up with them. So we can follow up with them to see if, in fact, are you getting your friends to be tested? And then the incentives, that always helps. There's other little details for me because I work at a university, record keeping. We implemented a REDCap database for our PrEP clinic, and then we just added a little tab for those involved in research. So I can easily see who's involved in research in our clinic. And then, of course, the institutional IRB hurdle that had to happen. So our side goals also for this particular outreach project is linking people to HIV and PrEP services. So this is just a little example. I know it's really hard to see. These are just regular size envelopes. On the one side has the, 1 in 7 people don't know their diagnosis, know your risk factors. The other side has our clinic phone number for HIV, which is Clinic 1A. And at Clinic 1A, we see 95% of all HIV positive patients in the state of Utah. So we have a huge catchment. We also see all uninsured people, all 100% of uninsured patients in our clinic. And then you see down below, or if this test is negative, but you want PrEP services, call this number. So there are actually 2 numbers. It's the same clinic, it's the same line. It's just we kind of wanted to make it a little bit different. And then below, we put our business card or our little card in these envelopes, which is what you see below the PrEP Community Clinic. So some roadblocks once we started this. So one was we had a delay in starting our free clinic. We were supposed to start in January. That happened in March 2018 this year. We had limited staff, like I said. So we haven't been able to get to every single patient to ask them if they want to be involved in this, just limited staff. And then the follow-up with seed patients. We have had follow-up, but not face-to-face follow-up yet. So we've had case manager follow-up and we've had physician calling with results, but not face-to-face. So I only have like really anecdotal things to report. And then the other thing we saw is that there were not many tests done in clinic. Like I mentioned, we wanted to have testing in our clinic if they came with a friend. Well, mostly if they came with a friend, it was either their HIV positive partner or it was with their friend that was already on PrEP, just to give more support. So we did do a few, but not a lot. And then again, we didn't have a good way to capture those linked to PrEP services. Now we do. We have everything standardized in our EMR as well as our database. So it's optimizations in defining success. So I mentioned we didn't have a lot of in-person testing. So what we decided to do is Pride was coming up, and our Pride Festival is actually, despite that we live in Utah, is highly attended. We get about 60,000 people every day. And so we were going to be there. And what we told our patients in May is that, hey, if you bring your buddy to our booth at Pride, we'll test them. And it worked. So this is just a little picture of some of our pharmacy students, our volunteers, and then in the far right-hand corner, you can see about 8 tests being done, and it worked. So we tested 45 tests in 2 hours. And again, these are all of our PrEP patients bringing their friends to get tested. We didn't feel bad about, not offering a test for other people because other people were testing people for HIV. So again, we were just testing our seed patients' friends. So far, we've tested 50 in-person tests. We've recruited 32 seed patients, and we've passed out a total of 110 access cards to get a free test. We have identified 1 positive. He was linked to care within 2 business days. And then, was I right with my demographics? Is this the target population? I don't know, but I'll tell you a little about our population. So 36% are minority, 98% are MSM, and about 24% or a quarter have an STI at their first visit, so they're clearly sexually active. And how has this gone over with our PrEP patients? So when we give our spiel about doing this, we don't say there's an incentive. All of them say they want to do it before we mention the incentive, so that's nice. And then nearly all of them also say the same thing. I have a lot of friends that need to be tested. You know, yeah, I do want to do it. I can name like 3 people off the top of my head, so that was really great. And again, these are people that have already been tested for HIV. They already have HIV risk reduction, so they're like their own little, it's like our own little PrEP champion to get their friends to be tested. And then just one little funny thing that happened. At our last clinic, one of our patients called a few days after clinic and said, I need more cards. I've passed it out all my 5, and I have 5 or 10 more people that need to be tested. So our seed patients are definitely working. So just some summary topics to think about is follow your passion. So whatever you're passionate about, you need to follow that. You know that. You can't do something half-hearted. You have to understand the problem, and that means doing some research. You have to know your target audience, and also if you don't know the target audience, maybe that's not the audience for you. If you really are intent in doing that, you have to work with a community partner. You have to talk how people talk amongst themselves. So to get to this population, I needed to get the friends. And again, you can never underestimate the power of social networks. Having that community or peer navigator or peer champion is definitely extremely reliable. And then obviously we need to be prepared to make tweaks and find ways to improve uptake. I think that's it.
Great, thank you so much for that. So our next speaker is a local star, Dr. MarkAlain Dery with Access Health Louisiana, and he's going to discuss the process of moving from the idea of outreach testing to launching the actual program. All yours.
Thank you. So welcome to New Orleans, y'all. This is a music city, as if you all have not already realized, as Essence just left this weekend. So this is going to actually really take the form of music, and as you were just saying, follow your passion. So I was a musician that became a physician that became a musician again. And so you'll see that theme kind of repeat itself, and it's going to ultimately culminate in something that I created called the Hamp Fest, because everything in New Orleans has got to have the word festival after it. Hamp Fest, which is HIV Awareness Music Project, and that's ultimately where we're going to head to. So quickly just kind of they asked me to talk about, I'm going to just kind of talk about Louisiana and talk about why HIV testing is so important and what inspired me kind of at the beginning of my career as I was an ID fellow. And then kind of help understand the decision-making process, review the planning process, and then the launching process, including our media. So I'm just going to do a couple, probably about 5 to 10 minutes of quick kind of background slide work, just to kind of put it in context. And a lot of this information is information you already know. But as we already know, that I think last year, this research came out that showed that people living with HIV live the length of life with the same quality of life as people who don't have HIV if they take their medications on a regular basis. That's good, because I've just always said that. And now I'm happy that there's actually research to actually show that it's true. I kind of assumed it was true, but no one ever questioned me on it. Now if anybody ever questions me on that. But one of my talking points whenever I have to give a diagnosis, I refer to it as the good news of HIV. The good news of HIV is people living with HIV are expected to live the length of life of people who do not have HIV, as well as the quality of life. This is called the HIV Care Continuum. I'm sure y'all have seen this. This is in 2015, which looks a little better. But essentially what this does is I refer to this as the vital signs of HIV or Hep C. And we're seeing it now in other fields of medicine as well. And whoever it was that first came up with this care continuum, kudos to them, because they've changed the visual landscape, certainly of HIV and of hepatitis C. But I'm showing essentially what we're trying to do is get to where the red is, that red bar, which kind of shows how many people are virally suppressed. Because we're at a point, and I'll talk about that in a quick second, as to where we can actually eliminate HIV. We can really be the first HIV-free generation We really can. I mean, we're getting that way with hepatitis C, but we can be that way with HIV as well. And I'll show you some of the work that San Francisco is doing. If we get everybody on HIV medications, there's no virus to transmit, right? So if our community viral loads or our statewide viral loads or our regional viral loads or our nation viral load is undetectable, we can really get to a point without a vaccine or cure. But that line that says receipt of care is the one that's somewhat vexing because what that really implies is that there aren't a lot of people, there's a significant amount of people, and certainly in Louisiana, that are undiagnosed of HIV. And that's really kind of where we're headed from. And in this slide here, difficult to see, but we can see here that the diagnosis of HIV, especially for Louisiana, there's something like 1 in 20 to 25% of people living in Louisiana, and that's the next slide, we'll get to that in a quick second, don't know they have HIV, and it's that minority of people we're particularly concerned about because it's that minority of people that are responsible for the majority of HIV transmissions, because those people who know that they have HIV, for the most part, will alter their behaviors and stop participating in behaviors that put them at risk for HIV in the first place. And I have a slide to show that as well. And so then they oftentimes, hopefully, will take their medications, and that helps to decrease the viral transmission. But this slide here shows that different populations of people are unaware that they have HIV. And the ones that really stand out are certainly the Native American population, and then, of course, those adolescents and young adults between the ages of 13 to 24, of which 1 in 2 don't know they have HIV. This, of course, speaks to our first speaker, who really is talking about the importance of getting out, especially to young people, and get them tested for HIV. This also, very difficult to read slide, essentially just shows that 1 in 4 people living with HIV in the state of Louisiana do not know that they are HIV positive, all right? So that's 20 to 25% of people. Just to give you context, around the globe, it's 1 in 2 people, 1 in 2 people around the globe that don't know they have HIV. So we certainly have a lot of work to do. This is the study that shows that about 68%, so almost about 70% of people will engage in new behaviors after an HIV diagnosis, and of course this is why it's important to diagnose. This is an incredibly important graph. I show it. I do not do HIV talks now without showing this, because in this graph, the city of San Francisco demonstrated that in less than 3 years, they can decrease the transmission of HIV by 50%. San Francisco, 50%. By instituting 4 very simple public health policies or strategies: HIV testing, PrEP, test and treat or same-day start, and increasing the number of case navigators or case management, retention and care, linkage to care, that sort of stuff. So those 4 again were increasing PrEP services, increasing HIV testing, increasing same-day start, test and treat, and then increasing linkage to care. Those 4 very simple parameters decreased. Is there anybody from San Francisco here? Or is it State Health Department from San Francisco? No? I just wanted to make sure I was not speaking out of line here. Because I have presented in front of the people from San Francisco, and I'm always embarrassed when they come to me and they say, "Thank you, that was my department. We appreciate the plug." Incredibly important, very, very simple, and we're trying to actually replicate some of that work here, not only in the state, but in New Orleans as well. Same-day start's important. Once we test them, we need to get them treated same day. We've seen some amazing data come out of South Africa and Haiti that show this. This study here in Haiti basically shows that there was a significant decrease in mortality in those people who were started on the same day. This study just basically showed that there was also same clinic had a decrease or an increase in retention and care, which is obviously very important, and as did the San Francisco study as well, and they showed that they were able to get to they were able to get to viral suppression faster, obviously, with same-day start. This, without question, most important study of them all, which is the HPTN 052 study, which essentially shows that if you get people on HIV medications, there is no viral transmission once they are undiagnosed to their intimate or sexual partners. I first presented this slide a couple months after it came out to about 1,000 internists at a very large group of general internal medicine doctors, and I was asked, based on the study, can we start telling our patients that they don't need to wear condoms with their stable monogamous relationships, and I said yes, and there was a big gasp in the room. And the whole U equals U had not come out at this point. And I was vilified for several years after that, especially with the doctors that were there, especially amongst my colleagues and friends who know me well. And they said I was crazy, but I wasn't. This project has been replicated several times, and we can see that with undetectable viral loads, what needs to happen now is we need to get our criminalization and our partners in the legal world and our police partners to also recognize that having HIV is not a crime, and the fact that people are undiagnosed, when they're undetectable, that they cannot transmit virus, and we need to stop criminalizing HIV. But that's well beyond the scope of this conversation, obviously. But what we're seeing here is that undetectable obviously means untransmittable. And this is probably the most exciting kind of campaign that we have seen recently. So it's unbelievably important to do HIV testing. Obviously, you can see where my passion is. HIV testing is unbelievably important for us to get to a point where we are truly the first HIV-free generation. We need to be able to start testing everybody. One group of people that I test regularly are nuns. You know why I test nuns? Because I can. Seriously. I say, can I test you for HIV? And they're like, sure. Like, why are you testing me for HIV? And I say, so that I can stand up in front of my colleagues and tell them that I test people, including nuns, for HIV. And they're like, oh, of course, test me then. So I test nuns. I test my parents. I test my in-laws. I test anybody. I'll test anyone. If you've got a mouth, I've got a swab, I'll swab you. Doesn't matter. And then I'll take a picture of it to kind of show how easy it is and how unstigmatized we need to make HIV testing. If I can test nuns, because there is right here I always call it a nunnery, and that's wrong, obviously. Convent. There's a convent right here. It's wrong. This is what happens when you put an atheist. And I'm an atheist, and they come to me. They come to me as their primary care doctor. I don't know why nuns come to me. I swear to God they do, because I do general medicine, and there's a big convent here, but they'll come and I'll test them for HIV, and if I can test for HIV, you guys can test anybody. So sometime back, as I said, when I was an infectious disease fellow, I really wanted to kind of start to take my love for music and kind of really focus it in on HIV testing. And so I came up with this mission statement. My wife actually did, who between the two of us is the much smarter and elegant one between the two of us. So she helped me kind of craft this message that I can think about on a regular basis, which she said that I need to aim high, which is advocacy through innovative messaging. And a lot of what I do is advocacy through innovative messaging, because I've now inadvertently found myself in the world of media, and I'll talk about that in a quick second. So Robert Fogarty did this big Dear World campaign after Katrina. I'm sure you guys have probably seen this campaign in one iteration. He's been all over the world several times now. Local photographer, after Katrina, started to kind of capture people's Katrina stories by messaging that was on their palms or messaging on their arms that were written like this. And so one day my number came up and I got called to go do, around World AIDS Day, maybe about a year after his campaign, he asked me to come into his studio and get tests, or to do HIV, to do this Dear World. So get tested for HIV. So again, Robert Fogarty, and he uses this as a campaign as I do. So around every World AIDS Day, I really try to put that out there to remind people we need to do testing for HIV. So as I mentioned to you, I'm also a musician. That's me playing upright bass there. It's not really quite the way that most people play an upright bass, but that's the way I do mine. So this is me playing at one of our local clubs. And so I show that picture to kind of give you guys an idea that for the stuff that I'm going to talk to you about now is easier when you're a musician. I understand that, okay? So I understand not everybody's a musician, and not everybody lives in New Orleans. Not everybody knows the musician world in New Orleans, but I do. I am a musician. I do know the musicians in New Orleans. And what did I start? I started about 10 years ago collecting them to have an annual HIV awareness show, concert, in the French Quarter, a couple blocks from here, usually at a place called One-Eyed Jack's, in which we do large-scale HIV testing events. And that's called HAMP, the HIV Awareness Music Project. And I was looking at that logo today, and it looks a little dated, and so part of this lecture tonight made me realize I need to kind of change that logo. And so as I mentioned to you, I'll test anybody. Doesn't matter. And so what I do is we do these mock testings on site. This event here, what you're seeing me do is basically mock testing. We're not actually taking those swabs and going to dip them in a testing solution at all. Obviously, that's totally wrong. But what we're trying to do, and what I try to do, I just got a brand new computer, and I'm unable to show my photos, so I don't have all the photos available. So I wasn't able to grab some of the bigger celebrities. But if you're a celebrity, I will try to do somehow, I'll try to get a picture of me testing you for HIV. And I was this close in getting President Obama. He was going to select me or somebody else, and it was a 7-year-old boy or me. And he selected the 7-year-old boy, and it was really cute. It was at Xavier, and the little boy's like, why does everybody hate you so much? Or why are these mean people to you? It was very sweet, and I was like, all right, dude, you won. Like, there's no way I was going to compete with that. But I was that close in getting the President Obama to do a swab. But what we do is we hold these large-scale testing events in which we show how easy it is to be tested for HIV. We have testing vans on site, and so we work with different, or at that time, I was with Tulane. I just recently moved over to an FQHC, so we'll be doing our own testing at our HAMPs coming from now on. But we'll do testing on site as well, obviously free and confidential HIV testing. I'll test anything. That's me testing a puppet, because we have these adult puppet shows here in New Orleans, and that's me. They built me into the puppet show for that night, and that character had a crazy night the night before in the French Quarter, and she came to me to go get tested for HIV. So that's me testing a puppet, because that's the sort of art we do here in New Orleans, where we kind of take the real with the puppets and kind of blend it all into HIV testing as well. So the things that, if this is something that you need to do, these are all various posters I was able to find, and I've learned to become very media savvy over the course of these last 10 years or so. But getting the media on your side is a great thing to do for you all. So should you guys decide to do these, and I brought plenty of cards, and I'd be happy to consult with you all as well, should you guys be interested in doing ideas like this, in which you are able to kind of talk to your musicians and get interested parties together so as to do these large-scale HIV testing events. For us, these are all very, very notable musicians here in New Orleans that are also very good friends of mine. You can see there at the bottom, Trombone Shorty played once, Kermit Ruffins, D1. These are all very, very big names, Rebirth, Soul Brass. So these are all folks that are all Quintron and Miss Pussycat. These are all people who are all very notable folks. And when I go and talk to them as to what we're doing and why we're doing it, we really do get a lot of really significant buy-in. And there's Charmaine Neville, me testing Charmaine Neville as well. So getting media buy-in, and getting media buy-in for HIV, for anything, is really easy. If you just need to know the right people and get people on board and let them know what you're doing. Then Time Magazine came down and did a big a 4-page kind of blurb on kind of all the different things that I've been doing for HIV here in New Orleans, and in particular testing. And you can see there, I just pulled a quote out there. Testing is single-handedly the most important thing to reduce new infections, as New Orleans has the highest rate of people living with HIV who are undiagnosed. And here the number they came up with was 77%. Because testing isn't as available as there are other parts of the country. So it's really important, and media is your friend. So I decided to take HAMP and I put it on the road, and we took it to Uganda. And after we did our first year, And so I brought some, I fundraised, we got some American musicians, we did it with a bunch of Ugandan musicians. We chose a place that has 8% prevalence of HIV in Uganda, and you can see these are the crowds that we actually bring in. So we bring in huge amounts of people because we're able to provide something that everybody loves. What do people love? Music. It is the single-handedly the universal thing that you can do that brings everybody together into one place, no matter what affiliation, political or what have you. Music is the thing that will do it. And there's actually biochemistry behind people's love for music. We respond biochemically to music. So what we do is they're not there to see American musicians, I guarantee you that. That rural area, they're there to see the Rwandan rappers and the Ugandan rappers. That's what they were there to see. We were up there just to play and do our thing. But in this was year number 2. We got about 10,000 people. And you could see those tents back there in the upper right-hand corner. We test about, I think that year we did about 10%, we estimated 10% to 15% of those, just because we just didn't have the time to test everybody. But everybody, once people got there and we were sitting and talking about what we were doing, people were really, really into it, right? And so here was a study that we submitted for publication that just recently was published, and we were in 2017 we got almost 50,000 people tested at 3 different sites in and around Uganda. So this whole idea of these large-scale music festivals really do work and really get people out. And right now I'm actually working on a project to do the same thing for HPV vaccine in Haiti, which is obviously a very, very different thing. But that's kind of where I've let this project go into other hands at this point, and I started focusing on a couple other things. One was this radio station idea just dropped in my lap, and so I started a radio station on my free time here in New Orleans called WHIV. It is a radio station that is dedicated to human rights and social justice. It's also my radio station. I own it, I run it, and as you can imagine, I also put a lot of HIV programming on there as well. One of the things that we were going to start last year was a very focused HIV testing programming, but my clinic flooded, and I got a grant funding for 1 year. I unfortunately had to turn all that money back. The idea was to do something what you were doing, which is offering incentives for HIV testing. And again, this is New Orleans. Welcome to New Orleans. It floods. You guys may be aware of that. We had a flash flood last year on August 5th. It's locally known as the August 5th floods. And my HIV clinic is in very low ground, and we got flooded, and that whole clinic got washed out. And so, but we do a lot of HIV programming. That's easy for me to do. I own the radio station, right? But it's not a radio station about HIV. Like my wife says, you give the man the W was fixed, or east of the Mississippi. I had no choice about the W, right? That was fixed. But I had 3 letters to choose from, and 3 letters arranged in that way I knew nobody else in the country had taken. You know, they said, come to us with 5 options. I'm like, yeah, I got 1 for you. They're like, what is it? I'm like, WHIV. They're like, yeah, no one else has that. So the FCC granted me that right away. So again, a lot of positive press, and with that lot of positive press, I'm able to continually talk about HIV. And one of the things I say, now WHIV is not a radio station about HIV, although it was founded by an HIV doctor. It's got HIV in the title. And probably one of the best things about WHIV is that I have people on air saying WHIV minute after minute, hour after hour, day after day, week after week, month after month, year after year. And how do you destigmatize a word? How do you take the power out of that word? Is that you repeat it over and over again, and that's what happens with WHIV. People now refer to the radio station as HIV. In fact, it's gotten to the point now where people will come and talk to me about HIV, and I'll have to ask them, are you talking about the radio station or about HIV? You know, like, oh no, the radio station. And people refer to WHIV as just HIV, they just drop the W and they just refer to it as HIV. That's how, kind of in a weird sort of way, it has become destigmatized. Initially, people were very like, ooh, WHIV, but now the power from that word has completely been eliminated because it has been repeated so much. So these are just various pictures of those folks that volunteer at the station and work at the station. So really wanted to do is kind of help kind of give you guys an idea of kind of what I do with respect to HIV testing and how I was going to say how easy it is, but I suppose that's easy for me to say. How with, like you were just saying, with the right passion and the right ingredients of people. And also, let me say, I'm the face right here and I'm the voice. This is impossible without a large group of people whose shoulders have lifted me to the point to where I'm at now. So this is not something that you do in a vacuum by yourself. It's really something that you really rely on teamwork to do, and it would take me another 20 minutes to thank all the people who helped get me here. But that being said, if you pull the right team together and have the right vision, you can actually get to do some of the really interesting things, at least for me, that I find interesting. And so that's what I do here in New Orleans. So thank you guys so much. I appreciate it. Thanks for having me.
Great, thank you so much for that. Now I'm going to ask our last presenter, Patrick Padgen, to come to the podium. Patrick's from the New York City Department of Health and Mental Hygiene, and he's going to discuss how to measure the success of testing programs and then how to use data to grow and change in order to meet need.
Hi, everybody. I'm Patrick. I'm from New York City. I work at the Department of Health in a program called New York Knows, and I've been there about 3 years. But I'm going to talk to you about the 10 years that we've been doing mobilized community testing in New York City. I'm going to briefly tell you a little bit about what New York Knows is, and then talk about some of the things I believe have led to the thriving success of the initiative, including supporting other jurisdictions in doing similar activities like we're doing. So first, I'm just going to give you a brief introduction to New York Knows. New York Knows is one of the largest, we probably could say the largest, but we try to be humble in New York City from time to time. It's one of the largest HIV testing and prevention initiatives in the nation, and it aims to help all of New York City residents learn their HIV status. It initially grew out of a pilot program in the Bronx called the Bronx Knows in 2008. Last month for National HIV Testing Day in June, the Bronx actually celebrated its 10 years. And if any of you are in the Bronx next week, let me know. We're having a big party to celebrate 10 years of this initiative. So the guiding principles of New York Knows are about community mobilization. We believe that mobilizing and engaging the community allows us to harness their voices and their interests to have better outcomes. We also believe in collective impact, that together we can accomplish more than we can alone. And finally, that HIV testing is a gateway to both prevention and to care. It's also a vital step in ending the epidemic. These are the current goals of New York Knows: to provide a voluntary test to everybody in New York City, to make HIV testing a routine part of care, and to identify undiagnosed people living with HIV and connect them to care, and connect people who test negative to prevention services such as PrEP. Our partners are currently hospitals, health centers, elected officials, colleges and universities, faith-based institutions, community-based organizations, and small and large businesses. We currently have about 211 signed community partners. And by signed, what I'm referring to is a pledge that we have. You can see this image is actually the initial pledge that we had our partners sign in 2008 with the Bronx Knows. We currently have a more updated electronic version. But this is a non-binding, non-legal agreement, but what it is a sign of faith that the agencies are going to be committed to the initiative. And this is important because all of the activities we do as New York Knows are completely unfunded. So all of our partners are doing activities with us out of commitment to the goals of the initiative and belief that what we're doing is going to further HIV work and end the epidemic in New York City. So what does it look like? We currently have borough-specific committees. That's 5 of them in New York City, and they consist of agencies that serve each of the boroughs, and they work to meet the needs and respond to the needs of each of the boroughs. We have 2 community co-chairs. These are respected leaders in the community who are elected by their peers to serve as leaders and guides in the initiative. One of them comes from a clinical site, such as a health center or hospital or a private practice, whereas the other comes from a non-clinical site, such as a community-based organization, a business, or a faith-based institution. We also do a lot of training and technical assistance. Since the beginning of the Bronx Knows, the Department of Health has led many workshops, trainings, and webinars, including a faith breakfast for community leaders in the faith community. We've also provided workshops on HIV testing law for all of our providers. We do agency-specific technical assistance. This is ongoing TA that meets the needs of all of our partners and specific to the requests that they have, and it ranges from what testing technology to use, how to get permits, or how to plan an event. And we also have an all-partner meeting, and this is an annual event where we have partners come from all 5 boroughs to talk about the successes and challenges we've had throughout the city, as well as highlight programs that are really working well, and talk about the cutting-edge ideas that are happening in the world of HIV, as well as looking at the future and thinking about next steps for the initiative. We have several population-specific initiatives that have come out of the New York Knows program. These include the Women's Advisory Board and the Immigrant Health Alliance. Both of these were initiatives that started out of our 2017 all-partner meeting. When we were talking about next steps, the community said we need to do more work for women of color, and we need to do more work for immigrant health. And so, both of these initiatives came out of that. We also have the Thrive Demonstration Project, which is a CDC-funded program that focuses on providing services for MSM of color in Brooklyn, and these include both care and prevention as well as supportive services for this community. We also have subcommittees and work groups that either focus on topics such as policy or on different communities, such as the faith-based community or youth. These are just 2 logos that we have from our Brooklyn United, Be Young, Be Brooklyn, Be Safe, and from Bronx Serving Realness, which is our Bronx Youth Club. So I'm going to talk a little bit about scaling up, how we grew as New York Knows. We initially started in 2008. In 2007, members of the Bronx community came to the health department and said, people aren't getting tested. We're finding a lot of people are coming in to get tested, and they're also being diagnosed with AIDS, so they were getting tested too late. It meant their health outcomes were worse. So they really wanted us to help them to provide access to people in the Bronx for HIV testing. As soon as we launched that in 2008, Brooklyn said, what about us? We're also an epicenter of HIV. What are you doing for us? And so we quickly followed up with Brooklyn Knows. And the Bronx initially was a 3-year initiative that went from 2008 to 2011. But Bronx said we want to continue, and we did the Bronx Still Knows for another 4 years. Brooklyn was a 4-year initiative from 2010 to 2014. And World AIDS Day 2014, we scaled up when we decided to launch New York Knows and collapse both Brooklyn and Bronx into the larger branch of New York Knows. And what that meant is we saw the launch of Queens Knows, Staten Island Knows, and New York Knows Manhattan Coalition. We don't call it Manhattan Knows because they didn't want to be called that. They wanted to be called New York Knows, and even though it causes us lots of stress, we respect their wishes. And I just want to acknowledge one of the things that I think is really important. When we launched all 5 boroughs, we also hired 5 different staff members, 1 to be responsible for each of the boroughs. We had tried in the past. When I first started, I was coordinating both Brooklyn and the Bronx. There was one day that I spent 6 hours on the subway traveling back and forth to go to meetings and events, and I said, I can't do that anymore. That's a long time to be underground. And we hired a 5th staff member, and really why this is important is because this is a full-time job, coordinating a testing program. This isn't something you can do, on the side, and it really, what we've seen is that a full-time staff member, the attention that they can give, responding to partners, meeting their needs, really has shown better outcomes for our initiative, including increase in testing numbers, increase in partner engagement, and increase in overall satisfaction. So next I'm going to talk about measuring progress. So this is our quarterly data report. We collect 5 different indicators, including the number of HIV tests conducted, the number of confirmed positives, the number of those confirmed positives linked to care, newly diagnosed confirmed positives, and newly diagnosed confirmed positives linked to care. We've used these same 5 data indicators since 2008 when we launched the Bronx Knows, and we keep these very simple because we wanted both our community-based organizations that are doing testing as well as our hospitals and health centers to be able to report this data, because ultimately it leads us to having a standard measurement that we can use to really track our progress. We also use our monitoring and our data to really highlight the success of the programs that are partnered with us. For example, when we first launched Bronx Knows in 2008, it was a 3-year initiative, but they met their 3-year testing goal in the second year, and we used this to highlight the great work that they were doing and really motivate them to continue to do such great work. And you'll see this again. On this chart, the gray line represents the 5-year testing goal that each of the boroughs had when we launched in 2014. The blue line represents the number of tests that the borough has done in the first 3 years. As you can see, the Bronx has more than doubled the number they were supposed to get in 5 years, and it's why they always say the Bronx is kicking ass. And if you look at Brooklyn and Manhattan, they're well on their way to getting their 5-year goal. Queens and Staten Island are 2 little brother boroughs, are struggling a little bit, but we've used a lot of interventions recently to help improve, doing technical assistance, having grand rounds in the hospitals, and really doing a lot of site visits at each of the testing agencies, and we've seen boosts in numbers in the last year. And just so everybody knows, the way that we calculated the gray line is we used surveillance data along with other survey data to calculate the number of people who had never been tested, and then created a goal for each of the boroughs. And when we first launched the New York Knows initiative, our goal was to conduct 2 million tests in 5 years. And currently we're at, or as of 2017, we were at 1.6 million. We also do other ways of monitoring. We have yearly borough objectives. Each borough creates a list of objectives that it wants accomplished during the year, whether it's a number of events to do, the number of tests to conduct, and we measure how well we're doing throughout the year. We do event or special project monitoring. We have a free test kit program. We have a pharmacy project where we do testing in pharmacies, which I'll get into later. And then we have a lot of special events, which I'll also talk about later. And we do a lot of monitoring to make sure that all of our activities are being carried out as intended. And being a social worker, I'm really interested in qualitative monitoring, and so that means really giving a chance for all of our partners to have ways to give us constant feedback, to really look at how well we're doing, because even though we are hitting our numbers, we may not be having the overall impact that we are intended to do, so we have lots of spaces for them to kind of contact us and talk to us about what we're doing, and it really gives us a deeper, more insightful idea of the progress of the initiative. In terms of evaluation, we do initiative reports at the end of Bronx Knows, at the end of Bronx Still Knows, at the end of Brooklyn Knows, and midway through New York Knows, we did initiative reports to look at our impact. We also do evaluations after each event that we do, and in 2017, we did a mid-initiative partner evaluation survey to really look at how well we had done for the first half of the initiative, and I'm going to talk about that a little bit later. We also use other existing data sources, including the community health surveys, sexual health surveys, and surveillance to tell us about trends in HIV diagnosis, PrEP usage and awareness, as well as testing rates in New York City. So our mid-initiative survey really was an attempt for us to get feedback from our partners because we believe in continuous improvement and being member-focused. Over 95% of our partners agreed that it was a successful collaboration, and over 85% agreed that they had gained, that their agency had gained something from being a part of the initiative. This is just a snapshot of some of those things that they said that they had gained. But not everything is perfect. We definitely heard some feedback about reporting data or about bringing in non-traditional partners and having a place at the table with them, and we've been working on improving that. We've done some quality improvement trainings, we've been reporting data more consistently, and we've also tried to make room for everybody at the table. So next I'm going to talk about maintaining innovation, and I think this is really important because the landscape of HIV is constantly changing. We know that testing fatigue is real, or at least in New York City. People tell us all the time. I've been tested, I've been offered a test every event I go to. We also have a lot of competing services and overlapping services. Like I said, we have 200 partners, a lot of them providing testing, and a lot of them going to the same communities and asking them to get tested. So we try to use innovation to find new ways to revitalize testing and make it interesting and fresh to promote it to our communities. One of the ways, that didn't show up right, sorry about that. One of the ways that we do that is through collaboration. That big blue graph, it should say that it's community-based organizations, and that's 42% of our partners. The red and green represent health centers and hospitals, and that's about 27% of our partners. And this one's not going to come out either. Okay. This is what I wanted to highlight, though, is what we call our non-traditional partners, and we define those as our partners who don't provide traditional HIV services, care, prevention, or testing. And if this looked correctly, you would see that that include colleges and universities, both small and large businesses, elected officials, and faith-based institutions. These non-traditional partners have been an essential part of our initiative since the beginning, and they've historically provided many things, including locations for testing, access to communities, data, resources, and a new perspective to look at things. And what I mean by that is when you sit around with a bunch of public health professionals and you look at public health problems, you tend to find public health solutions. So when we bring in people from the business sector or from the faith sector, they often look at things from a different lens, and it really helps us to kind of transform the way that we're thinking about some of these problems and trying to access some of these communities. Flexibility is important. And basically, I'm showing you the goals again, because this fourth goal we added in 2014 when we launched New York Knows, because PrEP, which is pre-exposure prophylaxis for anybody who's not aware, was a recent addition to the HIV landscape, and it wasn't around when we launched Bronx Knows in 2008. And why I bring this up is because it's really important to be responsive to what's happening in the world of HIV or into the world of the work that you're doing, and to be flexible and adapt to all these changes. Currently, right now, we're looking at how we can add goals around sexually transmitted infections and other new paradigms, for example, U equals U, and see how these can fit into our initiative. Meeting people where they're at, this is going back to my social work roots. This is really about understanding people's beliefs, their values, and where they are psychologically. It encourages us to adapt our interventions to meet the community and where they're at and really provide services that are appropriate for them. I think this really comes into play when we talk about stigma around HIV testing. We've done a lot of interventions that help to reduce this. One of those is routine testing. So we encourage all of our health centers and hospitals to provide testing for everybody that they see, regardless of demographics and regardless of risk factors. And what this does is it helps to reduce some of the stigma around who's being offered an HIV test. It also helps us to identify people more often and sooner because everybody's being offered a test, whether it's a 65-year-old married woman or whether it's a 20-year-old young man. We're offering everybody an HIV test, and we're finding out the positives a lot sooner. For New York Knows, we also look at meeting people where they're at a little more literally as in geographic setting, meeting people where they literally are. We go to street fairs and we go to different events, and this is where rapid HIV testing really comes into play. It's taking HIV testing out of the clinics and out of the CBOs and going to where people are. For the last 3 years, we've gone to Atlantic Antic, a large street fair in Brooklyn, and we've offered 100 tests every year while people are going to get barbecue, while they're listening to music, while they're buying goods on the street. We have a tent there with a big sign that says free HIV testing, and people come over and they say, well, I've never had an HIV test, or I've never been offered an HIV test, or I haven't been tested in years. So we're really getting to the community that is not being focused on or having access to HIV testing. This also works in our pharmacy testing initiatives. In Manhattan and the Bronx, we offer HIV testing in pharmacies in communities that are heavily impacted by HIV. Our partners go there on a weekly basis, 1 day a week, and offer free HIV testing. Again, this helps to reduce some of the stigma around testing. What we hear a lot in the community is, I don't want to go to that clinic, or I don't want to go to that CBO because they're associated with HIV, and if I go in, people are going to think I have HIV. Or they're going to think that I need an HIV test because I'm promiscuous or whatever is associated with HIV. So putting this into the community helps to reduce that stigma. And also, the great part about this in the Bronx, we've been seeing a lot of really elderly people coming into the pharmacy and getting tested who had never been offered a test before. New York law, up until recently, said you had to offer a test for anybody 13 to 64. Now it's changed, so it's 13 and above. But up until then, providers weren't offering tests for people who are above 64. And having worked in senior homes, they are definitely having sex. Nobody's just talking about it. We also do a lot of HIV awareness days. These are national days that commemorate various communities and activities around HIV. This is a large part of what we do. Recently, for National HIV Testing Day, we went to Union Square, which is a large park in Manhattan. We counted over 15,000 people coming through the square in 3.5 hours. We had 16 agencies providing testing. We had over 60 tables of agencies tabling. We had a DJ, we had cheerleaders, we had a drum line. It was a great time. Everybody had a lot of fun. And in that 3.5 hours, we tested over 300 people. We also do a lot of different events for specific communities. So the image on the left is for National Latino AIDS Awareness Day, which happens in October. We do an event called Take the Train, Take the Test, and we put mobile vans outside of train stations that have heavy Latino ridership to provide testing there. And then the picture right next to it is for National Gay Men's. We go to gay clubs and bars, as well as sex clubs, and we provide HIV testing outside of those in the evening until 3 in the morning. Relationship building is another piece that's very important. For us, it means relationships with our partners, but anybody in an HIV testing program needs to have a good relationship with the community. It's the only way to be successful. Communication is important, and this is both giving and receiving. It's not just telling people things, but it's also about hearing what people are saying and responding to it, and also finding the appropriate means for communication. For example, for National Black AIDS Awareness Day, we had an event where we were putting our agencies, testing agencies, with churches, and we gave them the email of the churches. And so in the end, nobody did any testing because the churches don't answer email. And so we realized, oh wait, that was a big problem of ours, because we thought, hey, let's just connect them through email. No, that doesn't work. So finding the right way to communicate with people, whether it's via email, whether it's stopping by, or whether it's a phone call, is really important. We also have an online resource called our New York Knows directory, and this is accessible for all of our New York Knows partners, and they can use it to find referrals, to update information, and really kind of engage with each other, which is really helpful. It's a networking tool that's been really successful. Individual connection is another piece that's really important. Like I said, each of us as a staff runs a particular borough. I work in the Bronx, and developing a connection with people is really important. I want to get, I think it's really, people look at me and they ask me all these questions about how do I get STIs, how do I get mental health, how do I get, substance abuse resources, because I'm their access point at the health department. New York City Health Department has hundreds and hundreds of people, and so instead of them cold calling people and trying to find a resource, they come to me first. And I think that really helps build trust and a sense of connection to the health department. Site visits are also another key part of what we do, and this is both visiting the agencies as well as visiting the agencies during their events. My favorite thing to hear is that I see you everywhere, because I'm in the community all the time, everywhere, at all the events, at all the meetings, and people see me and they start to realize that I am a part of the community. I'm not just somebody sitting in the health department doing things. And I would say one of the things that we've noticed is that when we do site visits, we see an increase in partner engagement. People start coming to meetings more, they start talking to us more, they start asking for things more. So this is a really great tool. If you're not already doing it, I think it's really vital to you building relationships. And I think ultimately this leads us to having a lot of trust and access to the community. In 2014, there was a meningitis outbreak, and the health department turned to the New York Knows initiative and said, we need to use your resources and your connections to the community to help stop this outbreak. And so we were able to connect them to the right people in the community. And because we had that unfettered access to our partners, the contagion was cut short. And the last thing I'm going to talk about briefly is supporting other jurisdictions. We do a lot of capacity building assistance for health departments and CBOs on a national scale. We talk about community engagement, collective impact, and HIV testing, social marketing campaigns, event planning, and outreach. We also provide resources, and these include all of our invitation documents and our launch materials. And this is, like I said, our new updated electronic pledge that our partners sign, as well as all of our promotional materials and assets, including flyers and posters and brochures and a ton of other tools. If anybody's interested, you can contact Melanie Graham, who's the director of SEBA, or you can connect with them through this email. And then I have to acknowledge a lot of people because that's what we do at the health department when we have a lot of people working on everything. So these are all the people that helped me in preparing this presentation. I want to thank you for all listening to me, and thanks to Orshore for inviting me. This is just a brief picture of the team that I currently work with. The guy in the purple hat is actually the Deputy Director of Prevention and is a medical doctor. So, you know. And if you have any questions, this is my contact. Thank you.
Thank you so much, Patrick. That was wonderful. Let's give another round of applause to all of our presenters. So I think we just heard 3 really great examples of what this looks like on the ground and some really helpful nitty-gritty details about establishing these programs, maintaining these programs, assessing the impact of these programs, and then using that data to improve these programs. And a big part of the work that NACCHO does is look to share stories from the field, and I think this was a great example of what the stories from the field are. So we'd like to open up now to your questions and really use this time for you to think about your programs back in your jurisdictions and what questions you may have for our speakers. So Kayla in the back in the yellow shirt has a microphone, so if you have a question, just please raise your hand. There we go, first one.
And speakers, there's a second microphone on the desk. My question is for...
You know what, I think I'm in the line of that. So it's for Susana. I wanted to know, maybe you mentioned it, what was the incentive that you were providing to your Cs for their referrals?
They get $10 for everyone they get tested.
I have 2 questions. Is your radio station available on iHeartRadio?
No, they won't take us because we're what's referred to as a low-power FM radio station. They only take commercial radio stations. We're a community radio station.
Okay.
But we do stream online at whivfm.org.
Okay, that was my next question, was online. And I have a question about when you hired the 5 people to go to the different boroughs. Were they from the actual boroughs they were servicing?
No, they were not from the boroughs we were hiring. We did try to recruit some people, but it just didn't end up working out. I mean, the health department in New York City is sort of constrained about who we can hire, so we really needed somebody with a master's in public health, and so we got people straight out of college, actually.
Okay,
Unfortunately.
thank you.
Another question? Yep.
In regard to testing, one of the challenges is community testing is always hard to link the people to care after you get positive result. Can you talk a little bit about how you overcome, or if you run into any of those challenges, or can you talk a little more about when you have positive result, what you do? Are you able to link 100% of them to care? And I guess all of you do community testing, right?
So the health department doesn't actually do any of the HIV testing. All of our partner agencies do it, but all of them have very strict protocol about how they're going to do it, and it depends. We review a lot of their protocol, but it depends on the different departments. If they are a health center or hospital, they will often connect them back to their clinic for care, whereas the CBOs have a MOU with the clinic that they'll refer to. And usually we try and get people in the next day. We have actually an 85% connection to care rate in the New York Nose. So we do a lot of this, and I think people have been doing it for so long, they really know how to get it done. And there's different ways, getting people's phone numbers, getting people's addresses, and a lot of people might have a burner phone or might have a phone that might not work tomorrow. So really finding ways that they can kind of get back in touch with the people.
So for us, it's the same thing. Whenever I do my events here in the French Quarter, we usually use a clinic that has a testing van. And as I'm sure it is in y'all's communities as well, we can only recommend, especially for a Ryan White program, can recommend various clinics, but they oftentimes will choose the clinic that actually tested them. And so there's very aggressive linkage to care strategies that get done here in New Orleans that occur when we do the testing in the French Quarter. In Uganda, it's a different story. We've got multiple partners, and they all have for them to partner up with us, we need to make sure that they have very strong linkage to care programs. At least that's what I went in there thinking I needed to do, despite 20 plus years of public health work. I forgot that, I walked in there, and I feel kind of foolish talking about it now, but I walked in there with linkage to care and la. They're like, yeah, this is our community. We know everybody here. So when somebody hits a positive, they know exactly where to find that person. And so their linkage to care issues there are, who was the person that tested positive? We're going to go find them and then drag them back into care. So the linkage to care in Uganda, especially in the more rural places, are a little bit easier because the clinic workers know who tested positive, or at least they're one or two persons separated, and so they'll be able to find those folks. But your point is otherwise well taken. The testing would be absolutely useless if there wasn't a very, very strong parallel linkage to care component to it as well.
So for ours, our in-person test is pretty easy because we're right then, and we're the only HIV show in the state, and we also are the largest PrEP provider, so that's pretty easy for us. And then we have multiple PrEP clinics. Our free clinic is the one that's most accessible, and then our university PrEP clinic, which is there are for insured patients. But also, if you think about the seed patients giving these cards to their friends, we don't know a lot of it. That's why we put some little advertising on the card themselves. But we also have our seed patients who know these patients really well. And I would say our seed patients are the biggest advocates for HIV testing. And the one person that we know is positive was drugged in by their friend. So we have to rely on them.
Any other questions? Yes.
Thanks. Now that thanks for the presentations. I'm just curious to see how, when you've developed a trust with the communities, how are you able to assess and offer any ideas or where they need to get care for mental health or suicide ideations or anything else like that? Mental health and suicide prevention efforts.
So we have a lot of different initiatives out of the Department of Health, and so there's people already doing a lot of that work. And so when the community comes to me and say we need these resources, I'm able to connect them with somebody. We have the Thrive Initiative. Currently, the First Lady of New York City is really invested in mental health and is this Thrive Initiative to really train everybody in New York City on assessing mental health. And so we're able to connect a lot of our agencies with those resources, those trainings, and so they can provide better resources around mental health. So we're really connecting. My goal is to connect, I like to say that I'm not the expert, but I know the experts, and so that's how I do a lot of my work, is that if you come to me and say, I need to know about this, I connect you with the person that does know about that.
All right. Do you have another question? Yeah, there we go.
For New York, I know you mentioned that you have set numbers that you try to reach every year, every 5 years. Is that considering targeted testing, or are you just testing everyone? What's your focus? And if you can talk a little bit about your testing protocols, that'd be great.
Yeah, so actually it's really interesting, I think, because our goal is to test everybody in New York City, and I think that often goes against what actually a lot of the contracts are for a lot of our partner agencies. And so a lot of times, we're like, let's test everybody, and they're like, but I have to get this many positives, and I have to test women of color, or I have to test MSM, or whatever. And so it's sometimes a struggle that we have, and we have different interventions that we use. We have a free test kit program, and that's unfettered by sort of, who you can test with it, and our agencies can apply to it and for awareness days or for a special pilot program, or if they're a health center or hospital that serves a lot of the community that don't have insurance, they can apply for this free test kit programs. We supplement a lot of hospitals, FQHCs, who serve people who don't have insurance with this free test kit program, and they can apply for it on a regular basis. So it is kind of a difficult, contradiction, because we're like, let's test everybody, and they're like, but I need to meet my numbers. So we really try to work that out with this free test kit programs, and also talking about different interventions that they can use for targeted testing, or we don't like to say targeted in New York City anymore. It's not, but looking at priority populations.
And what about funding for your shipping the test kits that you ship to individuals?
The free test kit program is funded by the CDC. Okay. But none of the testing that I do with New York Knows is funded. So a lot of the agencies have contracts with other departments in HIV, or with the CDC, or with other people, or the state, but none of the work that we do is funded. So they have other contracts that do that, or we have agencies like Housing Works, or AHF that fund through private, business. So that's how they get a lot of their funding. We don't fund anything.
Have any more questions for the panel this evening? All right, well, I think we will wrap up the formal component of this event tonight. I believe we have the room for about 20 more minutes, so definitely encourage everyone to stay, mingle amongst yourselves, speak to the panelists. Again, thank you all. Those were really excellent presentations, and I hope everyone has new information and that they look forward to bringing back to your communities. And so on behalf of Orshore Technologies and NACCHO, we hope you enjoy the rest of the conference, and thank you so much for attending the event tonight.